Hello, I'm Jack Cush from Baylor University Medical Center and Baylor Research Institute in Dallas, Texas. Today we're going to talk about serious infections with biologic agent use. As many of you know, when you look at the package insert that comes with many of the agents that we often use, drugs like etanercept, adalimumab, rituximab, tocilizumab, many of them begin with a black box warning that says serious infections may occur. Here's the product label from etanercept. It says risk of serious infections is a warning. Patients treated with etanercept may be at increased risk of serious infections, which may lead to death. So it's sort of a scary warning. It's often out there on the product label, also on direct-to-consumer advertising. So there's widespread knowledge that these agents may cause serious infections. And what's the data behind that, and should we really worry about it? Well, if you look at the historic risk of rheumatoid arthritis patients developing infection taken from multiple different sources, the average risk across many different patients seems to be somewhere between 3 and 9 SIEs, serious infectious events, per 100 patient years. When this is compared to that seen in the etanercept drug development program, they saw 4 SIEs per 100 patient years. And then when you look at the post-marketing experience with that drug, there's a far lower number, which is less than 0.6 SIEs, but you have to remember there's a significant amount of underreporting in the post-marketing era through MedWatch and other sources. So this number should be multiplied by 10, so it's roughly around 6. Again, it falls within that range of what one might expect in a patient with rheumatoid arthritis, certainly sick enough to go on a biologic agent. If you look at the actual risk that's listed in the package insert for all the biologics as shown here, across the board for the 9 currently available commercially used biologic agents, there seems to be about a 2-fold increased risk when you compare the observed SIE rate seen on the drug compared to the observed SIE rate to those taking placebo. The only exceptions here being golimumab and etanercept, where the rates seem to be equal to placebo, but overall even their studies show a slight increased risk in some studies. So is the takeaway message that there's a doubling of risk? Well, if you look at the data from the post-marketing experience, where it's a much wider range of use, less inhibitions as far as who you can and cannot use the drug in, there's a variance of rates being reported. So looking at 5 very large databases, Rabbit, the German database, BSRBR, the British Biologics Beta database, Artis, the Swedish database, Curtis et al. Looking at a large population of United Healthcare patients in Schneeweiss, a Medicare population in Pennsylvania, you can see the rate of SIEs in patients taking TNF inhibitors in these different populations range from 2.2 to a high of 6.3 per 100 patient years, certainly within the range of that I quoted earlier as the background rate. But when these patients were compared to their comparator group, patients taking DMARDs and not on biologics, the adjusted relative risk or rate that was seen was either 1, suggesting no increased rate, or 2 in some studies. So there seems to be a variance in these different studies, some saying that there was an increased risk, others saying that there wasn't. Again, if there is a risk, it seems to be a low one. Now, let's forget about rheumatoid arthritis and talk about the elderly people and their risk of getting a community-acquired pneumonia. This is a study of 11,000 elderly individuals over the age of 65, and in a 3-year period, the rate of community-acquired pneumonia, CAP, per 1,000 patient years of follow-up. In the elderly population, as you can see on the top, there were 14 pneumonias that were seen in 1,000 patients in 1 year. When you looked at the same population, but those who were immunocompromised by their definition, there was almost a 3-fold increase rate with 30 pneumonias. Chronic lung disease patients had a 46.5 rate, and chronic long-term steroid use also had almost a 4-fold increase rate of community-acquired pneumonia. How does this compare to rheumatoids and their rate of community-acquired pneumonia? Well, Fred Wolf, in using his national data bank, looked at this in almost 19,000 patients and showed 17 as the rate of pneumonia, so 17 per 1,000 patient years. But then when you looked at the contribution of therapy, they showed no increased risk for patients taking TNF inhibitors or disease-modifying drugs, but other risk factors that gave a hazard ratio of 2 to 4-fold increased risk included things like age, prednisone use, diabetes, myocardial infarction, and chronic lung disease. Hence, it seems that infectious risk in both normal people and patients with rheumatoid arthritis is driven by age, severity of background illness, comorbidities, and the use of corticosteroids. So this is seen in this study that was reported last year at the ACR meeting, where they looked at a cohort of individuals, and on the top you can see the rates of SIEs in those that are on DMARDs, TNF inhibitors, DMARDs with steroids, and TNF inhibitor steroids, showing a rate of basically less than 5 per 100 patient years. But in the middle bracket, you're looking at the same population, age less than 60, but they had a history in their past of a serious infectious event. And you can see there's a shifting to the right. Now take the same population, age less than 60, here a history of a prior infectious event, and now they have another comorbidity like renal disease. And you can see there's a further shift to the right. So the bottom line is, while there seems to be more in patients who are maybe on TNF inhibitors, it is these other factors that are also controlling the risk, the use of steroids, the presence of comorbidities. So overall, the risk of RA and infection, the best predictor of developing a serious infectious event in rheumatoid arthritis appears to be, above all, number one, rheumatoid arthritis itself. The disease severity, the debility of the disease, these are very important factors. In many studies, it has shown that corticosteroids contribute to risk. The comorbidities that are sometimes seen in up to half of our patients, things like renal failure, diabetes, heart failure, and especially patients with chronic lung disease, either interstitial lung disease, COPD, bronchiectasis. Lastly, breakdown of skin, your number one barrier against infection, is an important risk factor, as is joint surgery. What we do know is that there does not seem to be an increased risk with traditional DMARD use, methotrexate, gold compounds, leflunomide. There does not seem to be an increased risk of SIEs, but the bottom line is that when you are using a biologic, you may be at an increased risk, and it's a small but significant increased risk.